All right, welcome to Basic Arrhythmia 2019. This will be an entirely recorded lecture. My name is Leif Tobler. I'm a registered nurse. I work in the ICU, have done so for over 10 years now. So let's get rolling. Disclosures, I have no disclosures to share with you. This is just an educational activity, no conflicts of interest. Objectives and overview. I'm just going to take a little time. This is the high level, if you want the preface to everything, what we're going to talk about throughout the course of this entire process. Related, my goal here is for you to hopefully understand how the electrical activity of the heart is translated into the waveforms that we see on an ECG strip. There's a lot of stuff that builds that understanding, and I'm hoping to share that with you. The bigger part, which is the main reason why we're here, is to classify cardiac arrhythmias according to their origin, the mechanisms, their conduction, and talk about their prognosis as well, because arrhythmias aren't normal, and so at that point there's some effects that come from that. Moreover, I'm going to give you a way to interpret complex EKG rhythms using a systematic approach. No matter what source you look at, using the same consistent approach every time is what's going to help you make sure you don't miss any details, things of that nature, so that way you can hopefully organize all of this in your mind palace so that you can just look at a strip, walk through various pieces of it, and then be able to say to yourself, yep, that's what that is. And then finally, we're going to look at getting you to the point where you can just recognize frequently seen arrhythmias, things like AFib, but moreover, the lethal arrhythmias and life-threatening arrhythmias, rapid tachycardias, VTach, VFib, asystole, things of that nature. The organization of this lecture is as follows. I'll begin with anatomy and physiology, electrophysiology, all those basics, just to bring everyone watching up to speed with what the heart is like and what it has going on with itself. Oops, sorry. That's going to be a pretty big chunk, but I really want to lay out the important things so that all that setup's in place, so when we start talking about the rhythms and everything else, we can just plow right through it. Second part's going to be the rhythms themselves. I'm going to identify them and walk you through them. I'm going to have the examples there, and we'll look at all the different pieces using that systematic approach. There'll be an entire section on pacemakers, just talking about the details that go along with that, how to recognize when the pacemaker's not functioning appropriately, which is, of course, one of the reasons why we monitor paced patients. And then we'll do some practices as well. When all of this is said and done, there is a paper test that you will need to take, print off, go through, evaluate yourself, and then you'll turn that in, and that's how you'll receive credit. Electrical flow. So within this lecture, when I start talking about the rhythms themselves, I'm going to focus on the atria first, just kind of work down the heart from top to bottom. We'll talk about the sinus node, followed by the AV node, or AV, atrioventricular node. Then we'll have a whole little subsection on the AV junction itself. We'll talk about a few different things there. Then we'll move on to the ventricles, talking about the specific things that come up there, in particular PVCs. That's a big chunk, because that's one of the most common things we'll see. Of course, there's things like the bundle branches, what happens when those no longer function appropriately, as well as VTach, VFib, the really big hitters. Finally, there'll be that pacemaker section. Now, with the complexity part of it, within each of these electrical flow items, those are divvied up with, I'll talk about what's normal first, then I'll show you what happens when you have just a single inappropriate beat or ectopic beat that occurs through there. We'll talk about what happens when you have multiples of that, either that same ectopic beat or a varying type, just depends on what scenario we're in. And then finally, what it looks like when you have a continuous organized arrhythmia, where that single ectopic beat has taken on a life of its own and becomes all that that patient is producing now, not just occasionally. The list of rhythms. So here it is. This is kind of your, for lack of a better phrase, your index of what we're talking about, and the sequence we'll be talking about them in. That way, if you're ever curious of, oh, what comes next, or, oh, I knew it was somewhere in this area, this will kind of give you an idea of how the things are grouped together. So, anatomy and physiology. This is a bit of a larger section, but I feel like it's really important to the foundation of understanding where arrhythmias come from and why they happen. So the heart itself, it's the size of your fist. Go ahead and, as you're looking at the screen, ball up your hand, put it right in front of your chest. That's about the size of your heart, assuming everything's normal. It lies just to the side, just to the left of your mediastinum. So center of your chest is here, and the workhorse of it, the left ventricle, is here off to the left side. That's why we put our hand over the left side of our chest when we say the Pledge of Allegiance, because that's where the majority of your heart is at. It is actually tipped on its side. So when we draw a picture of a heart, we usually do something like this. Well, in reality, the heart's more of at an angle like this, tipped to its side. The heart itself is wrapped in a dual layer membrane known as a pericardium. So you hear about things like pericarditis. That's an inflammation of the pericardium. Cardiac tamponade, which is not really discussed here, but to point out, that membrane's really thick, so that pericardium can actually fill with fluid and can even in some cases wind up restricting how well that heart functions. Layers of the heart. While we won't be talking in great depth about the different pieces of this, I'm going to be using this language a lot, so I want to make sure you guys understand when I say it what I'm talking about. Now, the heart is actually inside out. So if you think about your arm has the skin on the outside, the epidermis, with the muscle, and then most internal of your arm is going to be your nerves and your arteries, veins, things of that nature. And so the heart is actually the opposite, where the epicardium, which is the outside of the heart, has your arteries, your nerves, and the lymphatics as well. Now, all of those feed from the outside to the inside of the heart. So as we move down, you then run into the myocardium, where myo means muscle and cardium's heart, so heart muscle. That's the workhorse. That's what does the contraction, the pumping, actually makes some action happen. The innermost layer, the endocardium, is actually connective tissue. It's cartilage. So this cartilage, it's thick, it's fibrous, and it's actually one continuous layer with the arteries and veins, which makes sense because you wouldn't want your arteries and veins to have this distinct division between the heart. That would create a rough edge, and then you'd have to worry about clotting and things like that. So from an evolutionary standpoint, that's why it's designed that way. Another important part about that endocardium, it's tough. It can take that wear and tear of that constant flow of blood moving past it. Other nice thing about it is because it's made of connective tissue, it doesn't really require a lot of blood flow, which is good because with most of the blood being at the outside with the epicardium, by the time it trickles into the endocardium, it's a little bit harder to get there, and so at that point, it's good that it doesn't need as much. Chambers of the heart. And hopefully everyone remembers from nursing school, you have 4 chambers in your body. You've got 2 atria, and those atria sit on top. So I'm going to go ahead and, actually I'm going to change my colors here, where you've got your right atrium here, which is the top section. I'll just outline that real quick. And then you have your left atrium that's on the other side, and we'll do LA for left atrium. And that's right here. So the question of the day is, do you know what or why they named them atria? This is one of the challenges of all anatomy physiology, is everything was named in like the 1600s by a bunch of guys where the words at that time made sense to them. And your atria is actually back when houses used to have parlors and things like that, well, the atrium, was the entrance to your house. And so for them, it made sense that you had the entrance to the heart. And so on the right side, you have the right atrium, and on the left side, you have the left atrium. So left entrance, right entrance. Now that's just the top half of the heart, so I'm just going to draw a line across here. And that's the top half. Now your bottom half has your left ventricle, and now you have two ventricles. And these are a little bit larger, they're stronger, there's more muscle to them because they're responsible for moving the blood to another area of the heart rather than within it. And so your left ventricle, which is this triangular shaped bit down here, is responsible for moving blood, and you can see this black arrow here, how it follows through. And the blue blood, the blood returning from the rest of the body, the used up, deoxygenated blood, the right ventricle moves that into the lungs. Now, after the blood has gone into the lungs and it's been oxygenated, it's turned red now, which is kind of just what we use as a naming convention. And that blood, oxygenated blood, returns from the lungs, enters the heart through the left atrium, left entrance, and that blood then gets pumped into the left ventricle, which is this triangular shaped organ here, and that's the LV. Now the left ventricle is then responsible for kicking that oxygenated blood out into the aorta and through to the rest of the body. One of the big challenges with this, because the heart is nothing but a big pump, you have to make sure that everything flows the correct direction. Now, each of the chambers of the heart and the arteries in which they pump is separated by a valve, and this valve prevents backflow from happening. Now, you have the atrioventricular valves, and we're just going to follow blood through the heart here to help keep track of things. So your tricuspid valve is one of your first ones that we run into. And so the tricuspid valve is this one right here in this location. So blood returns from other parts of the body through the inferior vena cava, superior vena cava, enters the right atrium, and from the right atrium it flows into the right ventricle. Now, when the right ventricle contracts, what that's going to do is actually put pressure in that system, and that pressure causes the tricuspid valve to close right here. And so when that valve closes, now as the right ventricle contracts harder, it will then force open your next valve, which is the pulmonic valve. Now the pulmonic valve separates the right ventricle from the pulmonary artery. Pulmonary is lungs, of course. So right ventricle contracts, opens up the pulmonic valve, and it pushes blood into the lungs. Now, blood goes through the lungs, it gets oxygenated, it turns red, and now we enter the left atrium. So blood returning from the lungs goes into the left atrium. The left atrium forces blood through the mitral valve, which is this guy right here. Now, that mitral valve separates the left atrium from the left ventricle. Left ventricle then contracts. When the left ventricle contracts, it closes the mitral valve and forces open this one right here, which is your aortic valve. And so you can see how these two have been named according to where it's going next, that the left ventricle contracts, opens the aortic valve, and blood flows through the aortic valve into the aorta and out to the rest of the body as such. Your cardiac cycle. Now, I just briefly went over this, but we're just putting it into words because it's important to think about these things. So, atrial systole, or systole, depending on how you like to pronounce that, is when both atria, and so this is both the right and the left, they happen almost simultaneously, contracting together. Both atria expel blood and push them into the ventricles. This is really, really important, and I'm taking the time to do this now because it'll come up quite a bit later, is that accounts for 20 to 30% of your cardiac output. And without that systole of the atria pushing it, atrial kick is also what that's known as. That atrial kick helps shove just that little bit more blood into the ventricles to really help fill them up to the brim so that when they contract, you can get more blood out. It kind of improves the efficiency of everything, which is why without it, your blood pressure and everything else will suffer accordingly. After the atria contract, and while they're still in systole, the ventricles begin to contract as well, and it's that back pressure. Now, notice that this is isovolumetric, meaning the ventricles contract, but no blood actually moves. It's almost like you have a balloon and you're squeezing it, but the balloon hasn't popped yet. This squeezing, this increased pressure, causes the valves to close, the AV valves. And I'm going to go back a slide real quick. So your AV valves, your tricuspid and your mitral, the one that separates the atria from the ventricles, those two valves will contract or will close, causing you the S1, the lub of your lub-dub. So as the ventricles contract, the pressure continues to build up, and eventually there's enough where you eject blood from the ventricles. And what that does is that opens the semilunar valves, so your pulmonary or pulmonic valve and your aortic valve. And when those ventricles contract at the same time, both the right and the left, blood moves out. And so now you have this top-bottom effect, essentially, that the top of the heart and then the bottom of the heart contracting. Oops, sorry, there we go, like this. And so you've got a top-bottom effect going on. After the ventricles are done contracting, they relax. Makes sense, just like any other muscle, contraction, relaxation. When the ventricles relax, what that does is creates a situation where there's backflow. So it's almost like when you're pushing water, you push water forward, like in a basin or a tub, that water's going to recede backwards. Blood's no different. And so when the ventricles contract, it pushes blood out, and when the ventricles start relaxing, that blood starts to work its way back. This is part of the genius of the design, is that relaxation diastole or diastole causes the aortic and pulmonic valves to then close. They opened up during systole, and now they're closing during relaxation. And so that's where you get your S2, your dub, so lub-dub. Finally, as those ventricles are relaxing, that lack of pressure is now allowing the mitral and tricuspid valves to open because now there's no pressure keeping them closed, and blood will passively flow in. Blood passively flows in, and then what do? We actually go back to right where we started with atrial systole, and cycle repeats over and over again. So top, bottom, contraction, relaxation. So the coronary arteries, this is how blood gets to the heart, plain and simple. Now, keep in mind how I'd mentioned before that the heart is inside out. You have flow from the outside to the inside. And so two main arteries feed the entire heart. You have one for the right side and one for the left. I like this diagram for helping explain this because it really shows the layout of it through the entire heart all the way through to the backside. And so we'll start with your right coronary artery, and that starts here. It's your RCA. And you'll notice that both of these branch directly off of the aorta itself through here. So right coronary artery then goes down. It feeds and wraps all the way around into the back side of the heart and even trickles down. So ultimately that right coronary artery is responsible for feeding a good chunk of the heart through here. As opposed to the left coronary artery, which instead of staying as one long branch, you actually have a left main coronary artery that branches into two sections. You've got the left circumflex, LCX, that actually travels around the side, and if you look through here, it actually gets to the back of the heart. Here, I'm going to grab an eraser. Meanwhile, your left anterior descending, so LAD, which is this one in the center, actually travels right down through the front of the heart. And so that LAD is responsible for kind of just this center and frontal part of the left ventricle. And that circumflex is then responsible for the side of the heart, the left lateral side of the heart, and the back side of the left ventricle. These are really important things to keep in mind, is just how important certain parts of the heart are. You have this right coronary artery that feeds all of this space on the far side. I'll switch colors here. So, this right coronary artery feeds so much space, almost 2/3 of the heart, whereas you have the left coronary artery, which is responsible for feeding only about the remaining third. And you can tell how important something is in the human body by how much blood flow it receives. Your brain gets a huge amount of blood flow because it's really important. Your kidneys are really important, so they get a lot of your cardiac output as well. And so just looking at this heart, you can tell that the left side of the heart is actually more important or does more work than the right side because it has all of this dedicated flow to make sure. In fact, it needs so much that it had to split into two parts to make sure that the whole of that left ventricle gets fed well enough. Final things to mention is that there's a septum in between. I'm going to go back a few pictures here. You also have, actually I'm going to go back to chambers, sorry. Within your heart itself, the center, the dividing point, your left and right sides of the heart are divided by a septum. And the most important of those is your ventricular septum. And it's this space right through here. This septum is pure muscle as well. so that when the heart's contracting, the septum itself doesn't move, but it still gets more solid. It contracts, it tightens up. And so that left anterior descending, the right coronary artery, like all of these arteries help feed that to make sure that it gets the energy it needs. But loss of your LAD, if that's not functioning right, a big chunk of the middle of your heart, the innermost portions, aren't getting the blood flow that they need. This is just a slightly different view. I think it kind of lays out the arteries a little bit better. You can't see through the heart, so it's not quite as confusing. But again, you've got your anterior portion of the heart, the front of your heart, is all fed by this LAD through here. Whereas you've got your right coronary artery feeding this section throughout here. And what's important to keep in mind is while that right coronary artery is feeding the big chunk of that front part of the heart and the inferior, which of course is this section down below, if you turn around to the back side of the heart, you'll see that this same right coronary artery is also responsible for feeding this huge portion of the back side of the heart too. Whereas your circumflex, your left coronary artery, left circumflex, LCX, is responsible for just this portion here. Again, illustrating how much more blood flow and energy that half of the heart needs compared to the rest. So, inwards, setting out some more of the important details that go with all of this. That right coronary artery, also known as the RCA, so I'm going to switch colors for that, sorry. The RCA, in almost half of people, and this is just average of the population, half of people have their sinus node fed by that. And we'll talk about the nodes a little bit later. What's really, really cool is the AV node for 90% of people is fed by that RCA. Which means if someone has problems with their AV node, it's probably their right coronary artery, statistically speaking. Last thing to go with that is the posterior descending artery, the PDA. People actually have a left or a right-handed heart. You don't really know this until you get your first heart cath, but there's a artery on the back side of the heart. I'll erase this so you can see it a little bit better. The posterior descending artery, I'll highlight this in green, is this guy right here. And what can happen is in some people, this circumflex artery actually connects right here and is the one that's responsible for feeding all of this rather than the RCA. And that's just more of an academic point, but it's still interesting to know that people can have a left or right-sided heart. To balance that out, the left coronary artery is going to be everything that the right coronary doesn't feed. Because if there's a section of your heart that doesn't get any blood flow, I mean, it just can't not happen. Everything has to be fed by something in your heart for it to function. So your LCA, left coronary artery, branches into your LCX, LAD. I want you to know these so that way when you're seeing notes or, they talk about where did you get your stent at, you can understand that, getting 3 stents in your LAD means that one of your most important arteries was pretty clogged. Your LAD, 2/3 of the IV septum, interventricular. So I talked about how that septum is so important. It's right there. It's the center of your heart. 2/3 of that thing is fed by the LAD. the remaining 1/3 is fed by your right coronary artery. So loss of your LAD is a huge hit to the function of your heart. Meanwhile, the left circumflex fee in the rest of the population takes care of your SA node, your AV node, and I talked about the posterior descending artery, how that can be a left-handed heart. I like these two pictures here because it helps illustrate something that's pretty important, and it's that the amount of muscle you have in your heart and relative to the other sections. So if you look at the picture on the right, we'll start with that one first, and we'll do this in green. See how thick the muscle is in your right atrium? This is your RA. Now contrast that with how thick the muscle is in your left ventricle. I talked about the blood flow, what's important, things like that. That right atrium, by comparison, is a thin slice of deli meat, and your left ventricle is a big thick steak. There's so much more muscle mass that makes up your left ventricle compared to your right, and that makes sense because the right atrium, and left atrium for that matter too, is also pretty thin. Doesn't have to work that hard. It just pushes a little bit of blood into those ventricles to help give them that atrial kick, whereas that, your right ventricle, this one here, is only responsible for pushing blood into your lungs. It's work, but not as much work as your left ventricle, who has to push blood to your entire body. To help wrap all this up, the actual structure of the heart, just to kind of visualize things a little bit, because the left ventricle is so important, it's the foundation of your heart. And the way the anatomy is actually laid out is it's almost as if your right ventricle through here was added on as an afterthought to the already existing left ventricle. And your left ventricle is shaped like a cone. It truly is. So that when it contracts, it squeezes from that narrowest part at the bottom out through the top, creating almost like, when you're in the swimming pool when you're kids and you take your hand and you squeeze the water and you can get it to squirt out the top. Exact same idea. So that your septum, which is this space through here in the middle, will contract first. And as that contracts, then the rest of the left ventricle wraps on it, and then the right ventricle is contracting onto that as well. It's as if you get that center part squeezing, and then the two side walls collapse onto it. Wrapping up how the blood flow and everything works. As you can recall, the right and left coronary arteries are fed directly from the aorta. Now, this is just really interesting in terms of asking the question, when does the heart get its blood flow? Now, when the heart contracts, that pushes blood out to the rest of the body. So your brain gets blood flow during systole. Now, think about this. If I asked you to lift something heavy and you had it in your arms and you curl your arms really tight, how long can you hold it there? Not forever. Eventually you'd have to let go. Why? Well, your muscles need oxygen and blood flow in order to contract. After a certain point in time, they run out of that oxygen they had. In fact, when your muscles contract, they actually compress the arteries so no fresh blood can get in. So relaxation is what allows that. So if the heart is contracting to give blood to the rest of the body, it's unable to get its own blood flow during that time. So here's what's so clever. During systole, which we talked about earlier, blood is flowing out of the ventricles and into the aorta. That opens up these valves right here on each side. When those valves open, they actually close the coronary arteries. Blood can't get into the coronary arteries while the heart's contracting. But when the heart relaxes, those valves go from being opened up like this. I'm just going to go ahead and make a very poorly drawn artery where the blood's flowing through, that when the ventricles relax, as the ventricles relax, those two valves actually close together like this in a nice curved fashion, so that blood that's coming backwards, that backflow, gets split and goes out through the coronary arteries on each side. So the heart, in fact, gets its blood when it's relaxed during diastole, the opposite time that the rest of the heart does, or the rest of the body does, which I think is really, really cool. The other diagram we have here on our right side is just to kind of show you the difference in how those arteries look during contraction and relaxation. So this is diastole here first, and when that muscle is relaxed, it's not nearly as thick. It's opened up. It's allowing all of that blood to flow from the epicardium down through all the way to those inner reaches, and in fact it spreads out nice and thin, almost like tree roots. But during systole, when the heart contracts and pushes blood to the rest of the body, muscle tightens up, and what happens is those arteries wind up compressing to the point where they're just completely closed, and in fact it's worse on the inside, and they're a little wider at the top, but for all intents and purposes, blood's not really getting anywhere in terms of the deeper parts of that heart, which is cool. Another really neat thing about that is the heart, when it starts contracting, actually starts contracting at the innermost part first, and then contracts more and more as you go out. So it actually shoves that blood back out the way it came, which is a good idea, because if you thought about it, if you contract the heart from the outside in the muscle itself, you'd wind up taking whatever blood you had collected right here and shoving it into the heart where it really wouldn't have anywhere to go. So clever design. This also explains why it's important that we keep our heart rate down. When your heart rate is running too fast for too long, you spend more time in this area where you're not getting very good blood flow. Having adequate relaxation time allows that blood to get where it needs to go and recharge the heart between beats. Ultimately, the big question is, why are we taking the time? Why is all of this so important? Well, for basic arrhythmia, it's not the biggest thing in the world. It's important to know. It can be helpful. But where it really pays off is larger things like heart attacks, STEMI, non-STEMIs, things of that nature, where if you actually hook a patient up to a 12-lead EKG, knowing where these vessels are, how they're laid out, and the way they function, you can actually discover where the problem is at in terms of a blockage or troublemaker, for lack of a better phrase. And that can really help out with treatments and things of that nature. Or if patients are having specific arrhythmias, you can tell that, oh, well, it's coming from that side of the heart, so I bet you that's the culprit. Let's investigate there.